times, 3 to 4 times greater than in singletons.
Thank you.
Happens sooner and progresses faster, and it's more severe and may appear in a typical way. Where is the evidence to support the statements? Well, this data is from Norway, where they compared the incidence of preeclampsia in twins compared to singletons. So in singleton, it's about 3.4%, while in twins was 11.8%. And adjusted those ratios is even adjusting for other risk factors like maternal age and BMI and other non-risk factors. The adjusted those ratios was 4.1, so 4 times higher, which is significant. 95% confidence interval does not include 1. And therefore, preeclampsia is even 4 times higher or more common in twins compared to singleton. This data is from the UK, where they looked at the cumulative incidence of preeclampsia and take into account that the risk of preterm birth is higher in twins compared to singletons. In fact, if you look, this is a graph, this is gestational age, the cumulative incidence of preeclampsia. The black line is a singleton, the dotted line I put here include diagonal twins, and the fine dotted, the red is the monochorionic twins. And in fact, if you look at the incidence of preterm preeclampsia, the farthest preeclampsia prior to 37 weeks, you see that actually twins about 9 times more or higher in the preeclampsia is 9 times higher, or preterm preeclampsia is 9 times higher in twins compared to singleton pregnancies. The obvious question is why, and there are a number of proposed hypotheses. Is it actually because there's a bigger placental mass and that leads to more androgenic markers or higher level of SPLT1, and that's obviously associated with increased risk of preeclampsia? Is it because maybe there's higher incidence of obesity? We know that there is an association between obesity and twin pregnancies. Is it maybe there is genetic or immune changes in twin pregnancies compared to singleton, and maybe this is increased risk of preeclampsia or associated with higher level of SPLT1? Is it because advanced maternal age was associated with higher chance of twins, and we know it's also associated with increased risk of preeclampsia, but also increased risk of other comorbidities like hypertension, for example, diabetes. I did say in the statement that tend to be more severe. Where is evidence of that? So if you look in women who have preeclampsia in twin pregnancies compared to women who have preeclampsia and they have singleton pregnancies, you see that the risk of abruption is significantly higher, as well as the risk of preterm birth. So here in singleton, 0.7% compared to 5% in twins, 6% in singleton, 35% in twins with preeclampsia. The other statement is the fact that twins and multi-pregnancy are usually excluded from studies, despite the fact that they have disproportionate contribution to excess or increased perinatal mortality and morbidity and healthcare costs. And where is the evidence to support that? Well, we see that out of the trials, for example, on fetal growth restriction, only 8% recruited both singleton and twins, none were limited to multiples. And this is all data, so I think the more recent figure is slightly better, but still there is huge inequalities. And for preeclampsia, only 17% recruited both singleton twins, not limited to multiples. And there is an ongoing randomized control trial of aspirin in twin pregnancies. But I'm focusing in this talk in prevention of preeclampsia in twins, and I'm gonna talk or focus on the data on aspirin and the data on progesterone. So for aspirin, we know the aspirin trial. We know that in women who found to be at higher risk of preeclampsia following first trimester screening using the FMF algorithm, giving them 150 milligrams from the first trimester until 36 weeks reduces the risk of preeclampsia. This is the same case in twin pregnancies. We published this meta-analysis. We looked at aspirin for prevention of preeclampsia, not just preeclampsia, but also adverse perinatal outcomes in twin pregnancies. And when we included the studies, we found that actually when you look at the combined or the pool effect, yes, aspirin was associated with a lower risk of preeclampsia in twin pregnancies, and you hear 0.64, so about 35% lower chance of developing preeclampsia. What about other outcomes? So with a fetal constriction or even gestational hypertension or adverse perinatal outcomes, there was no significant difference. But interestingly, the preterm births prior to 34 weeks, there was a significant difference. So giving low dose aspirin to twin pregnancies was associated with a lower risk, about 35% lower risk of preterm births less than 34 weeks. And this meta-analysis included 9 studies, included about 2,200 twin pregnancies. What about the aspirin dose? Would it make a difference? So in this meta-analysis, we did subgroup analysis, and for the studies that had aspirin dose more than 100 milligrams per day, there was 3 studies, 100 twin pregnancies, and the risk was lower. So about 50% lower risk of preeclampsia. While studies that had aspirin dose above 80 milligrams per day, it's only 2 studies, and the difference was not statistically significant, but that also could be a matter of power. What about the gestation age starting aspirin? Well, if you look at the studies that looked at aspirin started prior or before 16 weeks, 2 studies, and it was associated with significantly lower risk of preeclampsia, again, about 50%. Okay, well, if we stick just with the aspirin dose for prevention of preeclampsia in twin pregnancies, and we published this analysis observational data from St. George's, where I work, and we looked at that whether the aspirin dose matters. In this analysis, we included this observational study, this retrospective, so women were giving aspirin according to the NICE guideline, which is if they had one of the risk factors. They had the traditional risk factors. Since the publication of the aspirin trial, we actually started giving 150 milligram. The protocol changed to 150 milligram compared to 75. Before that was 75 milligram. And we looked at the difference. So here, this is women who did not take aspirin because they were not at risk. And the incidence of hypertensive disorders about 5%. While in women who had risk factors, so with a high risk of preeclampsia, and they were given aspirin 75 milligram, their incidence of hypertensive disorders was about 11%. They were high risk anyway. And the same risk factors that were given 150 milligram per day, the incidence was 1.8%. So the incidence in those who were given 150 milligram was significantly lower than the one that had 75 milligram a day. And therefore, this data would suggest that actually giving aspirin 150 milligram is better or more effective in reducing the risk of preeclampsia compared to 75 milligram. What about progesterone? Well, last year, this paper was published, this meta-analysis was published in British Journal, APEC-UK, and this looked at giving a natural progesterone, vaginal progesterone, for prevention of hypertensive disorders in pregnancy in singletons. And in this meta-analysis, when you look at when you give progesterone in the first trimester compared to placebo, which were randomized control trial, the incidence of preeclampsia reduced the risk of preeclampsia. The risk ratio 0.71, about 30% reduction in the incidence of preeclampsia. The results were different when the progesterone was given in the second or third trimester. The difference was not statistically significant. So this data suggests that actually in singletons, if you give progesterone in the first trimester, you reduce the risk of preeclampsia by 13%. So we wanted to look to see whether there's similar effect in twin pregnancies. Is giving vaginal progesterone effective for prevention of preeclampsia in twin pregnancies? So we looked at our data. We included more than 2,000 pregnancies, and analysis excluded the one that had chronic hypertension or structural anomalies or miscarriage or termination or higher order pregnancies. With outcome of preeclampsia or gestation hypertension. And of course, because of the NICE guideline, if women had any of these risk factors, the recommendation is to give aspirin. And therefore, we really, if we are looking at the effect of progesterone, we have to take into account that this woman, some of the women who have these risk factors, were given aspirin. So we did Cox proportional hazard model, adjusting for maternal age, BMI, ethnicity, and smoking. And this is, as I mentioned, we have more than 2,000 human pregnancies. We included 1,800. The hypertensive lotus pregnancy was 10%, preeclampsia was 5%. And this is the four groups of analysis. The group that had aspirin only, glucose aspirin, the group had progesterone and aspirin, the group had progesterone but no aspirin, and the group had neither progesterone nor aspirin. And this was the incidence of preeclampsia. If you see no aspirin, no progesterone was 7%, aspirin but no progesterone was 4.6%, aspirin and progesterone 7.6%, and progesterone and no aspirin was 5.8%. And therefore, actually, the one that had progesterone and no aspirin was not lower. In fact, the one that had aspirin or progesterone was actually lower. And this is analysis, again, the four groups, and this is delivery without developing preeclampsia. And you see, of course, the one that had no aspirin, no progesterone, because they were low risk. The one that had aspirin and no progesterone also seems to be, it reduces the risk of preeclampsia, but progesterone, no aspirin was not lower. And the same pattern you'll see when you look at the hypertensive disorders in pregnancy. Progesterone did not reduce or not associated with lower incidence of preeclampsia in twin pregnancies. And thus was a conclusion. The standalone micronized vaginal progesterone, or even its combination with aspirin, was not superior to the use of aspirin on its own for reducing the risk of preeclampsia or hypertensive disorders in twin pregnancies. So I'm going to stop here. Thank you very much for your attention, and I'm happy to take any questions.
Thank you very much. That's very interesting data. And anyone wanting questions, please raise their hand or put something in the chat, and we'll pass the questions on. But as I'm waiting for that, I'll start as a privilege of the chairman. One of the interesting things always is about twins and singletons, the difference between twins and singletons, and suggesting there is either partly a different etiology to this condition. And what's interesting is that aspirin seems to have an effect, and aspirin's always, people have wondered where aspirin might be effective, whether it's a sort of a beginning of the process or towards the end of as the process that takes place, whereas progesterone appears to have an effect really at first trimester and placentation development. So, and it doesn't work. So it's suggestive that there's some other factor related to twins. And have you? And the problems of twins is the numbers are always smaller because they get hold of them. But as you know, that people like assisted conception and particularly donor eggs at far higher risk. Again, have you any idea of your data looking through that to see if there's any trending of different types and hinting towards etiology?
I think you're absolutely right, and thank you so much for your for actually highlighting this point. And I removed some of the slides, but sort of screening for preeclampsia in twins because of obviously the time and the focus of the talk was in aspirin and progesterone. But if you look at the prediction models or the screening markers for preeclampsia, they perform far less in twins compared to singletons. And even FMF algorithm, for example, the performance in twins is less accurate in twin pregnancies compared to singletons. It's much higher false positive rate. And we tried recently, we worked with American collaborators. We looked at the CDC data. And you're right about the fact most of the twin studies suffer from the small numbers. But actually looking at the CDC data, we had 600,000 twin pregnancies. So to some extent we had power. And again, with whether you use the traditional approach of logistic regression or whether we use the machine learning or AI, is still the performance AUC was maximum about 0.6 or 0.65. And therefore, our ability to predict preeclampsia using the traditional risk factors is far less in twins compared to singleton. And that's precisely because of what you said, is that the mechanism of preeclampsia in twins is not the same as in singleton. So yes, you would probably see a component of placenta insufficiency. Yes, it contributes. Yes, probably a component of maternal cardiovascular dysfunction. Yes, it contributes, but this is not the only reason, because as I said, when you apply the same prediction models, the performance is far less in twins compared to singleton pregnancies. Regarding assisted conceptions, we also published data from large number, I can't remember, maybe 30,000 twin pregnancies. And assisted conception, even when you adjust for all the other potential confounders or other risk factors, is still associated with higher risk, about 2 to 3 times higher risk of developing preeclampsia compared to twin pregnancies conceived spontaneously.
And do you have any data on donor egg?
Yes. Yes, so associated with even higher risk. So even among those with assisted conception, having a donor egg is associated with even higher risk of preeclampsia. And I suspect it's the immune theory. So I suspect you see all the various theories, you see the footprints in twins, but they are far less in twin pregnancies compared to singleton, or certainly our ability to predict if you use these markers are far less in twins compared to singleton pregnancies.
Okay, well, thank you very much. That's fascinating work. And it's lovely to see you again. So